We are very lucky to have with us live in the studios this morning Dr. Margaret Flowers. Dr. Margaret Flowers is a Maryland pediatrician with experience as a hospitalist at a rural hospital and in private practice. She is co-chair of the Maryland chapter of Physicians for a National Health Program and congressional fellow for PNHP. She is also on the board of Healthcare Now, on the Maryland Universal Healthcare Action Network, and on the steering committee of the Leadership Conference for Guaranteed Healthcare. So start out, let's start at the beginning. How did you decide to initially become a doctor?
Oh, goodness. I guess that really came from me from just being very curious about the human body and how that works and trying to understand that, and just my natural desire to really make a difference in people's lives, to be able to do something to help people. That started at a young age. So. And
pediatrician, you like working with kids?
Well, that came because two things. One is I look very young, so to adults, they look at me and they're just like, "Oh, you look like a child yourself." To kids, I don't have that issue. I look old to all of them, but I really felt like kids are an opportunity. If you can start a child off right, if you can give them a healthy beginning, teach them healthy habits, that can last their entire life. And so I just felt like that was something that I wanted to be part of.
All right. And in your bio, you're listed as a hospitalist. What is that?
Right. After my residency training, my first position was working in a hospital where we stayed in the hospital full time. And so a large part of my job was with newborn babies, attending deliveries and resuscitating infants when they needed that, and then overseeing patients on the pediatric ward and being in the emergency room when pediatric cases came in. So just being there present for whatever rolled in the door.
So how did you go from working on that issue to working on issues of healthcare overall?
Yeah, big switch. So when I was first working, and I came out of residency, I felt like I'd had a very good training. I worked really hard. I was ready to come out and provide quality care, and that was really my mission in the community where we worked, this rural community. We were very proud of the fact that we could take care of very sick kids and keep them in their community, in their own hospital close to home. I started running into the insurance company as the problem. They would deny the stays for children in the hospital that we felt were necessary. They would tell us what we could and couldn't do, and it wasn't based on good medicine. And so you find yourself suddenly, and other doctors I talked to are doing the same thing. How do you word it so you can get the care for the patient that they need? How do you sometimes you have to negotiate with the hospital. Are they going to eat the cost maybe so that you can keep patients in the hospital that need to be in? And that didn't make sense to me. And then when I moved out into private practice, started running into the same issues with insurance companies trying very hard to not pay us for the work that we had done. You have to go through so many hoops to try to get paid, but also telling us what our patients could and couldn't have, and then actually requesting their private records, which to me was just outrageous, that I would have to send a copy of a private encounter between myself and a patient to an insurance company to prove that I delivered the care that I say that I'm delivering. So it just became increasingly, to me, intrusive, and also the model that private practices have to adopt now is seeing more and more patients and spending less and less time with them, and you can't provide quality care that way. So it just was a growing awareness in me and looking at what is going on, in the bigger picture, where I felt like I need to get out and do something about this, because I also saw that my colleagues, and oftentimes it was the doctors I felt like were the most committed, who were leaving practice because of the environment, and we just can't sustain that.
So where did you go from there? What did you seek? Did you seek out existing groups that were already working on this?
Well, I stumbled across, actually, Physicians for National Health Program. I was kind of doing the research and looking at what were the health laws, what had been tried, how had that worked, and learned about Physicians for National Health Program and went to their conference to learn more after reading more on their website. And when you look at it, for decades in this country, we've been trying. The United States is unique in the way that we finance our healthcare. Of all the industrialized nations, we're the only one that uses this multiple, fragmented private insurance for-profit, industry to finance our healthcare. And so if you look at what's been tried to patch that up, there have been, expansions of public programs. There have been subsidies in different ways to help people purchase private insurance. But overall, none of those have affected the real change that we need. None of them have had the comprehensive or effect or really change things at a fundamental level to get us where we need to be. So as a result, for decades of patching things together, the expenses have gotten higher. Our costs are continue to rise faster than our GDP. The number of uninsured continues to grow. We never keep up with that. Our outcomes continue to worsen. And so when you look at what Physicians for National Health Program advocates, which is really looking at the policy, the evidence of what works, creating that fundamental change, that to me became a no-brainer. I'm not going to waste my time at something effective. It's like I wouldn't give a patient a treatment that I know doesn't work. Sometimes you just have to say, this is what works and this is what we have to go for. And it's a political challenge, but anything else I think is a waste of time.
So expand on that. What is it specifically that Physicians for National Health Program are trying to enact?
Exactly. So the simplest way to think of it for people in this country is Medicare for All, is an improved Medicare for All. So we have a system in this country where it's nationwide. Once you turn 65, you are in that system. You can choose your doctor. The doctors and the patients are the ones, for the most part, making a decision about their treatment. There's no kind of insurance middle person in the way saying what you can and can't have. So we advocate for expanding that and improving it. We need to make it more comprehensive. Really what we're talking about is creating like a nationwide system that's publicly funded. So all of our healthcare dollars go into a single public fund. That's why we sometimes call it single payer, which can be a confusing term. And then we take those dollars and we use them to pay for the health system, to pay for all the health services that we need. From the patient perspective, it means that you're covered from the time you're born until the time you died. You're in that system. You can choose where you want to go. From the health practitioner perspective, it means that we're the ones in charge again of making the decisions with our patients for what treatment they need. And it's about health. It's not about profit. It's not like we have a company that's denying care because that's how they make their profit. So it's continuous, it's comprehensive, and the beauty is it's one set of rules. So for patients, I know it's very hard trying to figure out what the rules are, where you can go, what you can have. For practitioners, it's very hard figuring out because the rules often change. So it's one set of rules that makes it much simpler.
And you mentioned Medicare. Can you define the difference between Medicare and Medicaid?
Yes. Medicare is a system that we set up 45 years ago for everybody who turns 65 and older is eligible. And it's public financing that the money is collected through taxes on our payroll. And then it's privately delivered. You choose what doctor you want to go to, what hospital you want to go to. Medicaid is a program that's for people. It's administered at the state level, so the rules change, based on the state. Medicaid serves our lower income population, and who's eligible depends on what the rules are in that particular state. But Medicaid has certain restrictions on it because it's funded at the state level. States have to balance their budgets, and so when states have a budget crisis like we have right now, it's often the Medicaid programs that end up getting cut. So that's happened over and over, and we're going to see that now in this next go-round. So it tends to be a lower quality program because it's under serious budget constraints all the time.
All right. So in the corporate media, a lot of arguments come up against the concept of single payer and what you're proposing, one that it's, socialized medicine, that they're doing something like this in Canada, and the Canadians don't like their system. I mean, they're streaming across the border. That's why we have to put up a fence.
Right.
It's all those people coming across the border.
Yeah, and that's in this country, the corporations that profit off of our current situation are very powerful. It's the insurance companies, it's large hospital corporations. They fund our political campaigns. They have tons of lobbyists at our state and federal legislatures influencing the process to maintain that profit for themselves. They also have links to our mainstream media. So there's many of the people that are on these boards of these corporations that are profiting off the situation are also on the boards of our mainstream media, shaping that message. And so there's a lot of misinformation out there, and that those aren't true. We call a single-payer system civilized medicine because we're the only industrialized nation that doesn't have a system like this where we take care of our people. It's what civilized nations do for their people. The Canadian system has a very high satisfaction rate. 86% of their population is satisfied with that system, which they spend half of what we spend per person, and they have better health outcomes than we do. So this is why our job is a challenge, but it's important, and it's really right now it's about education. It's about letting people know that having a single payer national health system or trying at the state level, if there's efforts at that level as well, is based on the evidence of what works and does give us the things that we need. One way to look at it in this country is personal liberation. Things happen in this country that are so outrageous. People marry for health care. They divorce for health care. They stay in abusive marriages for health care. They are tied to their jobs that they don't like. Maybe they would like to start a small business, but they're afraid to because if they have any kind of condition themselves or in their family, they may not be able to afford health insurance. People going bankrupt. The greatest cause of bankruptcies in this nation is medical costs. These things don't happen in other industrialized nations. And so that's important for us to understand that we're abnormal and it doesn't have to be this way.
Talk more about costs because, again, in the corporate media, they talk about that your system that you're proposing would cost us more. And if it's bankrupting these individuals, wouldn't it bankrupt our nation further?
Right. And that's the crazy thing is the deficit commission that was convened this past year, we worked very hard to get this message to them, but of course they didn't really want to hear it. But we as a nation, because we have hundreds of different insurance companies, we spend the most per person per year of any other nation. That's because we have this huge administrative piece. A third of our healthcare costs go to marketing and administration, not direct patient care. And so we have hundreds of people that are developing these insurance plans and marketing them to people, and then we're trying to figure out which plan to buy, and then when you're in a plan, where do you go for care? There's all this bureaucratic mess that's wasting $400 billion a year just on that, which we could actually use to pay for care. So if you look at our health expenses compared to other countries, we're spending twice as much per person. But we're leaving 51 million people out completely. And we're leaving similar tens of millions of people who are underinsured. So they have these high deductible policies, these copays that leave them unprotected when they have a serious illness. They can't afford the care. So we're already paying enough for universal comprehensive health care in this country. But we're just wasting so much money on this bureaucratic nightmare. And so a single-payer system streamlines that. Our traditional Medicare in this country, we only spend 3% of that healthcare dollar on administration. It's very simple to use. So that would free up enough money if we go to a single system to actually cover everybody. And then the other thing is just the Deficit Commission made it very clear that healthcare costs were a problem all around, that they're rising faster than our GDP, but they're also holding down our businesses. Our global competitiveness is hampered because of healthcare costs. Our small businesses have a very unfair burden of healthcare costs, which causes them to not be able to hire or to hold their wages down. So it really has an effect on the whole economy. Our healthcare costs do, and a single-payer system. Not only can we provide comprehensive care for what we are currently spending, but it actually is the only type of system in which we can control our health care costs because we get rid of that whole kind of profit motive that's driving things right now.
And do you have any evidence that the people here in the U.S. are open to and or supportive of the single-payer system?
Yes. at poll over poll has shown that actually the majority of the population, despite the misinformation that is out there, supports a single-payer system. So we've been seeing around 65% pretty steadily of the population that supports this. And then if you look at the physician population, there was an interesting nationwide poll that looked at physicians of all specialties, and it was done in 2002 and then repeated in 2007. In 2007, it was 59% of physicians in this country support a national health insurance program, and that was a 10% increase in just that 5% period. So that really mirrors what I'm seeing as I travel around the country and speak to physicians, is that the situation that we're in right now, much like I experienced when I was in practice, is so broken, and there's such a level of discontent amongst our physician population that I think that's going to be very key. Is that health professionals need to stand up and start being more vocal about what's going on, and the support is there. We need to make ourselves visible.
So if this would just be an enlarging of or basically would be Medicare for all, another thing that you see in the corporate media is people saying that doctors are in fact having to leave their practices because of they can't get enough from people who use Medicare Medicaid. Have you heard that?
Well, people do say, they're concerned about the reimbursement. That's the only piece of Medicare that I think is a big issue for doctors, is that if you look at Medicare, it covers our population that's 65 and older, and also our disabled population. And so that's our most expensive population to take care of. So they're constantly under kind of a financial pressure to how do you use your dollars wisely to take care of that population. And part of that has been holding down reimbursement. Under a single-payer system, this is the beauty of it, is that every person is paying into the single system, and so you're sharing that risk. So it ends up, being less expensive for each person, but it also allows you to use your health care dollars to take care of that whole population. And actually, only about 20% of our population at a time is a high health care user, but that changes. Like, any one of us can be in that 20%. So when you have a system that's there, we're all paying in, it's there for you when you need it, when you're in that 20% that needs the high health care costs. So, it's about sharing the risk, which is what insurance was supposed to be, right? That everybody knows the more you pay in, the more people that are paying in, the less it is when you're the one that needs it.
All right. And also this was actually more coming out of people reacting to the Obamacare, was that people are fearful that they'll be directed towards doctors that they don't want to go to, or, a system that they really don't want to participate in. How would that be affected by a single payer?
Well, under a single payer system, it's a completely open network. Every physician, every hospital, every health professional is in that network. So you have complete choice as a patient of where you want to go. What we have right now with private insurance companies is that they restrict their networks. They tell you, you can only see these certain doctors, but that goes away under a single payer system. So it actually, it increases our choice. It also gives us a real sense of what we consider to be security. If you look at other nations, when people get sick, they don't have a sudden fear of, don't know if I can pay for this, or maybe not, I can't go to the center where I want to go to get the care. That changes under a single-payer system. You can, if you're traveling around the country and you get sick, you just go in. You're part of that. If you're in the country, you're part of that system. You go and you get the care wherever you are.
So talk about the new current system, what people are calling Obamacare. What doesn't it give us? What, if anything good, does it give us?
Right. I, as you mentioned, served as congressional fellow during that health reform process. So spent a lot of time in Congress, and it was really interesting to see the amount of industry influence over that legislation. So we ended up with this really complicated, huge piece of legislation that had to be complicated to kind of serve all of the various corporate interests that they were trying to appease. So what we ended up with is really reform modeled on what's been tried in Massachusetts and hasn't been working there. And it basically says, if you qualify for a public program like Medicaid or Medicare, you stay in that. But anybody else who doesn't qualify is forced to purchase private insurance. And then we're going to take billions of our public dollars and use that to subsidize the purchase of this private insurance. But there's no control over how much the private insurance companies can charge for these premiums. So that was, a big part of the problem was we said, look, just don't force people to purchase private insurance. Don't use our public dollars to subsidize this industry, which is already profiting greatly. But that's what we ended up with. So it's going to continue. We just didn't make the fundamental change that we need to make. So they're estimating that we'll still have 23 million people with no access to insurance when the legislation is fully rolled out. We anticipate it will be much higher than that. It's going to drive people, because there are no caps on the premiums, we see this as driving people into purchasing health insurance, which is a trend we currently see, that has less and less coverage, more and higher deductibles, higher copays, and less benefits that are covered. So we're going to wind up with more people that are underinsured and financially vulnerable if they get sick. And in the legislation, we see it as also kind of incentivizing employers to start dropping insurance benefits, because it will be less expensive for them to pay. They have to pay a certain cost per employee to help subsidize that employee to purchase private insurance in the individual market. It'll be less for them to do that than to continue to offer health benefits. So we see there was an article not too long ago in the Wall Street Journal, basically, where they said no business wants to be the first one to drop employee benefits, but everybody wants to be second. So it just didn't, solve the problems that we have.
So were you then siding with the recent wave of Republicans coming in that we should dump Obamacare?
No, there's a difference between those who are screaming about repealing the law and those of us who are fighting for real health care reform. They're more about politics and, trying to make the Democratic Party look bad right now. Their solutions that they offer are really not solutions. None of them have been proven to be effective. We don't want to repeal the law. We are just saying that we haven't finished health care reform yet. We haven't done it yet. Even the president was honest enough to say at the end that this was health insurance reform, not health care reform. And so we're still fighting for real health care reform.
Talk about that. You've been literally brought before Congress. I mean, you've spoken before Congress on, I think, multiple occasions. And in fact, it's not officially on your bio, but you're one of the Baucus 8. Correct. So can you kind of talk about that a little bit and your experience trying to work within the system?
Yes, and actually I'm privileged to be here in Seattle with 2 other members of the Baucus 8, and we'll be speaking tonight at University of Washington at 7 p.m. at Kane Hall, Mark Dudzik and Katie Robbins. We had been meeting with members of Congress starting in December of 2008 and saying to them, as you move forward in this health reform process, we'd like you to also consider the legislation that we have in the House and the Senate, the single-payer legislation, and compare what you're putting together with what we are advocating for on the basis of how many people are covered and how much it would cost. Because we knew that ours is superior. Single payer is universal. It's a single system where everybody's in and nobody's out, and it controls our health care costs. As we got to the time when they started the hearings in the committees in the Senate, which was the first body to take up health reform, we had asked to be able to testify at those committee hearings, and they turned us down. Instead, they invited the CEOs of health insurance corporations, the lobbyists for health insurance companies, lobbyists from pharmaceutical, big business. They were all at the table, but there was not one person speaking for the majority of us that support a national health program. And so when we were excluded, we really came to a point where we had to make a choice. Are we going to give up? Or are we going to expose the fact that this is happening? And so we did go, 8 of us, 3 of us were physicians, 2 lawyers, 3 health advocates, went down to the Senate Finance Committee hearing, and as they were starting, we stood up one by one and asked why we weren't being allowed to testify, and we were arrested. And as a result of that, I was invited back to testify before the next committee. Senator Kennedy was still alive, so his committee contacted me, and I was the first person to testify in the Senate Health, Education, Labor, and Pension Committee. But that's really what it takes. How are we going to break through this corporate control of our political process? It's going to take breaking out of what we've been traditionally doing. While It's important to have legislation. It's important to work that legislation. That alone is not sufficient. We're going to have to stand up and find ways to shift the balance of power back towards the people so that we can fight for what we actually need as a people.
So you're an activist both at the legislative level and out in the streets. One can go to YouTube and find numerous situations where you're out with a sign,
Right.
sometimes getting arrested for
Right.
just trying to talk to the president. How do you see this as fitting into with other issues and strategy from here on out?
Yeah, thanks for asking that. If we look at health, what do we want? We want a healthy population in this country. And access to health care is just one small piece of that. It's more of our health care is actually determined by what we call social determinants, which are having adequate education, a job with a living wage, a safe place to live, clean water, affordable, healthy food, and even how you're treated, being treated with dignity and respect, having, equal rights. All of these things come together to create a healthy society. So we see access to health care as one piece of the broader movement in this country for social and economic justice. The United States has the greatest wealth divide if you look at the industrialized nations, and that wealth divide is growing. And if you look at our what are called indicators of social well-being, we're an outlier. We're abnormal compared to all the other nations. And so what we really need to do in this country, if we want to create a healthy society and get the changes that we need, is see that the work for social and economic justice is all connected. And so lately, I've been trying to find ways to demonstrate that. And so I was very proud to join the Veterans for Peace at the White House back in December. They had the largest veteran-led anti-war action. 131 of us were arrested that day. And they were very welcoming to me and invited me to speak to them about how the issues are connected. And they're starting to include speaking about health when they're, out fighting against the war, that, we need to be using these war dollars here in this country to pay for the things that our people need. And so we've got this, this corporate control, and they have a lot of money. But what they don't have are the votes. That's our power as a people. And so we need to, there's kind of two things we need to do. One is joining ourselves together and showing that voter power, expecting our politicians to be accountable. And if they're not doing the things that are in our best interest, we should stop voting for them, because that's a very powerful message to them. The other thing is that we need to start being in the streets more and being more vocal and louder and having effective actions and saying, as far as healthcare goes, if, a clinic is being shut down in your community, if a hospital is being shut down, if someone's not getting care, we need to be out there fighting for that and saying this is wrong and making our demand very clear and very visible.
And as you mentioned earlier, there is the money available to do all this, contrary to what people hear.
Which is why, as a physician, I do this work that I do, because I find this situation in this country completely unacceptable. We spend the most of any nation per person on health care, but yet we leave a huge proportion of our population out. We have health outcomes that in some areas of our country rival third world nations. And it doesn't have to be this way. And how can we practice with integrity in a country where our health system is ranked 37th, in the world? It's up to us. We can change that. We have what it takes. We have great hospitals. We have the money. We have caring health professionals. We just have to come together and fight for it and say that we want to be one of the best health systems in the world. That's where I want to practice, in a country that has one of the top health systems, where I can be proud of what I'm doing and serving my patients well.
All right. Well, with that, we're unfortunately out of time. I want to thank you very much for coming and spending time with us this morning.